Having reviewed over different disturbances over the past few lessons that we talked about for the pleural space, it's time to actually talk about the basics of our chest tube and its setup. Alright you guys, welcome back to another video lesson from ICU Advantage. My name is Eddie Watson, and my goal is to give you guys the confidence to succeed in the ICU by making these complex critical care subjects easy to understand. I truly hope that I'm able to do just that, and if I am, I do invite you to subscribe to the channel down below. When you do, make sure you hit that bell icon and select all notifications so you never miss out when I release a new lesson. As always, the notes for this lesson as well as all the previous videos are available exclusively to the YouTube and Patreon members. You can find links to join both of those down in the lesson description below. Also, don't forget to head over to icuadvantage.com or follow that link down in the lesson description to take a quiz on this lesson, test your knowledge while also being entered into a weekly gift card. As well as don't forget that you can help support this channel through the purchase of an ICU Advantage sticker. Again, those are found at the website icuadvantage.com/support, link down in the description. Now, this lesson here is going to be primarily referring to the pleural chest tubes. Mediastinal chest tubes will eventually be covered sometime in the future. Now, while some of this information does apply to both, there certainly are some important differences there as well. So let's start out with a quick diagram and review of our entire setup from our patient to the wall. So here we have our patient. And then here we're going to have the chest tube that's inserted. We're going to have tubing that comes from the end of our chest tube and goes down and then goes to our collection chamber or our chest drainage unit. And again, if you do want to understand more about the drainage unit, I'm going to link to a lesson up above where I really went in depth about the physiology and how all that works. Then from the drainage unit, we have the suction tubing that will come off and then go to our wall suction. So having this whole setup here, there's actually a few different things that we need to be assessing and monitoring for our patient as well as the system. So I'm going to go through and talk about a lot of those things here. So first, when it comes to the patient, some things that we're specifically looking for in our patient. So obviously we're going to be, listening to breath sounds. We're going to be monitoring their oxygen saturation. We're going to be looking for that symmetric lung expansion on both sides. But we're also really going to be looking for signs of respiratory distress. So here think our tachypnea, our rapid shallow breathing, if they're using accessory muscles. These could be signs that either there's problems with our chest tube setup or that things aren't draining properly. Definitely things you want to be keeping an eye on. Another important thing to assess for a patient is actually going to be their pain level. Having a chest tube can actually often hurt the patient. And the pain that they have from the chest tube is actually going to prevent them from taking good deep breaths, which is going to be really important when they have this in. And so here we do want to be using our analgesics to help relieve this pain for our patients, both from a comfort standpoint, but like I just mentioned, also an ability to take those good deep breaths. And then for our patient, if they are awake and obviously not sedated and on a vent, we do want to be encouraging things like taking good deep breaths, coughing, as well as ambulation as well. Now from there, the next thing that we want to be talking about is going to be the drainage that's actually coming from our chest tube. So we want to be keeping an eye on the color, the consistency, as well as the amount of drainage that we have. Some important things to keep in mind are, is this changing at all? Now, typically over time, we do expect to see our drainage, if it was initially sanguinous or bloody, that over time we should eventually see this lighten up and transition more to a yellowish pleural fluid or something with a slight pink tinge to it, a serosanguinous drainage. But if it's actually going the other way, and let's say we have something like frank blood, that's obviously going to be a big change that we're going to need to alert the provider for. And then especially if we're having that new frank bloody drainage and it's greater than 100 mLs an hour, that this could definitely be something concerning. Also for the chest tube in general, if we're having greater than 200 mLs of drainage per hour, this is again something that we're going to want to keep an eye on, as well as potentially letting the provider know as well. Now, when it comes to monitoring this drainage and this output, initially we're probably going to be recording this at least hourly. Obviously, for certain situations, we may actually be doing this more frequently than that, but typically initially every hour we're going to be doing this. As time goes on and that drainage slows up, we can move to more time in between each assessment. So, Q4 hours or potentially even every shift if the drainage is pretty minimal. Now you can actually make marks on the front of the drainage unit. So on the side where the level is that shows you how much drainage you have, typically we'll make a line across there and then put the date and time on there so that we know when we were at that point, and then obviously document that in your charting system. And then patient movement and positioning can really help to facilitate drainage from the chest tube. So having your patient in like a semi or high Fowler's position is actually going to be the best, as well as if they're in the bed, the rotation from side to side is going to help to kind of move that fluid around and again help to facilitate drainage out via the chest tube. Now, this movement, particularly like if you get your patient up out of bed and into the chair, that this can actually lead to an increased amount of drainage, but this is something that's going to be expected, and it's not going to be concerning if it just happens initially and is not a persistent high volume drainage after that. Now, from there, we do want to focus on the dressing for our chest tube. So obviously, is it clean, dry, and intact? We're going to be doing at least daily dressing changes on that, so you want to make sure that you have the date and time on there. But if it is becoming saturated, if your patient is having a lot of drainage around the outside of the chest tube, then you may need to change this chest tube more often. When it comes to doing that dressing change, it's really important that we are cleaning and prepping the site with either CHG or betadine, povidone iodine. And so here we want to be cleaning the entire area around the chest tube as well as the chest tube itself, at least up 2 centimeters from the insertion site. Once we've done this, we want to put gauze in and around the site. So this is either going to be 4x4 gauze pads or drain sponges. Drain sponges are certainly preferred if you have that, and then you just want to put that around the chest tube and kind of alternate the angle of the opening. But if you don't have those available, you can just use the 4x4s, and then we want to put, typically we'll do like folded 4x4s up underneath the chest tube, and then we'll lay the fully expanded gauze on top of it, and then securing everything down with chest tube tape. In addition to securing the gauze at the insertion site of the chest tube, it's also important that we do an extra piece of tape further down on the chest tube, securing it to the patient. And the point of this is that if anything is pulled, it's going to pull on where this chest tube is taped to the patient down below instead of pulling on the insertion site itself. Now, one thing to also keep in mind too is that you may potentially use something like Xeroform around the insertion site. Now, this is typically more common in traumas, and the point of this is it really helps to create an airtight seal. So moving on, let's actually talk about the insertion site itself. And so really the first thing we want to keep an eye on is whether there's been any kind of movement to that chest tube. And really, is that chest tube moving outward? Because obviously this can cause some problems if it becomes dislodged too much. So it's going to be really important that we're getting daily chest x-rays for these patients. And so we do want to be taking a look at this chest x-ray and making sure that that chest tube is still in place. And the big thing that we're looking for is that the fenestrations or the holes that are at the end of the chest tube, which help to facilitate that drainage, that they're still in the pleural space within the chest wall. And so here's an example of that on x-ray, just to kind of show you. It's pretty easy to see here along the chest tube, there's actually a radio-opaque line that shows up, and then there's a gap that you'll see up here towards the end, and that's to mark where the fenestration begins. So as long as that part is still within the chest wall, then we know that we're okay. If it moves out from there, then this is where we potentially create a path for air to communicate back into the pleural space, potentially leading to a pneumothorax, and obviously can cause problems. Now, our chest tubes are also going to be secured with sutures, so we do want to evaluate those sutures, make sure that they're still intact and secure. We also want to be keeping an eye out for signs of infection, so things like redness and swelling, if our patient has a fever, if there's any discoloration of the skin around there. These are things that we want to be keeping an eye on with that insertion site as well. We also want to pay attention to and note whether there's any drainage coming from around the outside of the chest tube. And here we want to be keeping an eye on the type and the amount of this drainage. And then lastly, we also want to assess the area around the chest tube insertion site for signs of subcutaneous emphysema or subcu air. And this is essentially where air gets trapped underneath the skin in the tissue. Now, when this happens, this is something that we call crepitus, and if you've never felt it before, I promise the first time you feel it, it's going to be very obvious. It's a very unique feeling. It's always been described as like Rice Krispie kind of popping and crackling feeling as you're pressing around the skin around the insertion site. If you do notice that your patient has crepitus, you want to mark the area where that crepitus is. Sometimes initially for new chest tube placements, especially for our traumatic situations, that it's not necessarily uncommon to have subcutaneous emphysema and to notice this crepitus in your patient. But like I said, it's really important that we mark around where that area is because we want to make sure that the area isn't expanding. Obviously, if that sub-Q air is expanding, that crepitus is moving further along the patient's chest and up towards their shoulder, their side and back, things like that, we know that we have a problem. This is something the provider needs to be alerted to. All right, so now let's talk about some of the things with our actual drainage unit itself. And the first thing is actually going to be the position of it. It's really important that we have the drainage unit below the level of the insertion site and below our patient essentially. The reason for this is if we're above this point, then we're just not going to have drainage coming out from our patient, and that's the whole point of having the chest tube. Now the next thing when it comes to the drainage unit is to keep an eye on something that we refer to as tidaling. So essentially, tidaling is going to be the oscillation of the water level that's by our water seal. So over to the side, we've got the level here with the ball that's in there. And as the patient breathes, you're going to potentially see this moving up and down. And this is actually going to be normal as a result of the changing intrapleural pressures throughout the respiratory cycle. So for spontaneously breathing patients, on inspiration, that this is going to create more negative pressure, which is going to cause a rise in the water level. Then on expiration, they have more positive pressure, and so we're going to see that water level fall. So as they breathe in, it goes up, and they breathe out, it goes down, and it tidals up and down. And so we actually have the opposite of this occur for patients who are on the ventilator. And so here the inspiration is going to be the result of positive pressure causing the level to drop. And then on expiration, that this is where the pressures are going to drop. And so here we're going to see the water level rise. And so we're going to have tidaling still existing, but just going the opposite direction we would see with a spontaneously breathing patient. One thing to keep in mind is that tidaling is going to be more apparent in patients where we actually have suction off. When we have the suction currently on and hooked up to the drainage unit, that this is going to decrease the amount of tidaling that we can potentially see. And so what happens if we see that tidaling has stopped? Well, this could mean that the patient's lung has actually fully expanded. This could mean that we have an air leak, which I'm going to talk about here in just a minute. Could also mean that we have a kinked tube or some sort of obstruction. So make sure that if the tidaling stops, especially if you had it, that you want to make sure and assess your system, make sure that everything is okay. And so sometimes we'll actually end up with a very high level of water there for the tidaling chamber. And this is really the result of persistent high negative pressure. So if the patient is coughing a lot, taking big deep breaths, sometimes that can lead to excessively high negative pressure. If you do see this though, you can actually on the back of the drainage unit, there's a button that you can press that helps to release this pressure and bring the level back down. But make sure that you're only doing this when you have suction on. And then the next thing I want to talk about is another very important thing, and this is actually going to be air leak. And then an air leak is going to be shown as bubbling in the water sealed chamber. And so we actually have marks down there that help to quantify how much air leak is taking place. Typically they're marked anywhere from 1 to 5, and then the higher the number, the more bubbling and the more of an air leak that you have. And then when it comes to assessing an air leak, we can either have intermittent bubbling, continuous bubbling, or it's just not present. And do know though that especially for patients that have a pneumothorax and a new chest tube, that this bubbling and air leak is actually going to be normal initially. Anytime we have air moving through the system from the patient outward, this is going to cause bubbling in the water seal, showing us an air leak. So again, as we're evacuating air from that pleural space, we would expect to see an air leak. Now, if our patient has a persistent or a continuous air leak, this is definitely something that we want to keep an eye on. And if it's new, this is definitely something we need to alert the provider for. But there can be several reasons on why we would have this persistent air leak. So for the patient themselves, if they have a alveolar pleural fistula or a bronchopleural fistula, something like that that is allowing air to continue to go from our respiratory system into the pleural space, that this would then continue to have a persistent air leak. And some risk factors for a patient here are for patients on steroids, those who've had significant trauma, if they've got non-compliant lungs, emphysema, if we have them on high PEEP or high pressures, that this can lead to damage, as well as if they have significant scar tissue, that these are all risks for our patient. Now, a persistent air leak can also be the result of the insertion site. So if we have excessive space around the chest tube, that this could potentially allow air to be getting in there. Again, this is where one of the benefits of something like Xeroform would be helpful, as well as, like I just talked about earlier, the chest tube dislodgement. So if we have those fenestrated holes outside of the pleural space, that could also allow air into our system. This air leak could also be the result of a problem with our tubing or the connections that we have on our tubing, as well as, although rare, it could potentially be a result of a problem with our collection chamber. Now, if we do have a persistent air leak, especially a new persistent air leak, that we want to identify where it is coming from. So one of the first things we can do is actually pinch around the insertion site. If this pinching and pushing the skin up around the chest tube stops the air leak, we know that that's where the cause is potentially coming from, and something like Xeroform might be beneficial here. Now, if that doesn't fix it, then what we're going to do is take a set of clamps and we're going to briefly clamp the chest tube. Now, it's really important that we don't clamp this for more than a few seconds, at most 10 seconds, because especially if our patient actually has a continuous persistent air leak, something that's driven by a problem internally, that this can actually lead to a tension pneumothorax, which, as we've talked about previously, can be a potentially life-threatening situation. So we just want to do very short clamps. So we want to start clamping the chest tube itself. If we clamp the chest tube itself and the air leak goes away, and we've already previously identified that pinching the skin around the insertion site did not make it go away, that this means that the air leak is coming from the patient, some of those potential causes that I just talked about. Now from there, we want to clamp below our connection point where the tubing and the chest tube come together. Again, if it stops here, we know that the leak is coming from that connection, and so we want to really ensure that we have a good tight connection there. If it's still persistent, we want to work our way, clamping about every 12 inches down the tubing, trying to identify where the problem in the tubing might be coming from. And then finally, if we've done all of that, we still have a persistent leak despite clamping all the way down at the bottom, then we know that this is the rare case where we actually have a problem with our collection unit, and then we would need to change it out at this point. Again, most important thing to stress here is that we absolutely do not want to be clamping that chest tube or the tubing any longer than just a couple seconds. Alright, so next we want to be assessing the suction that we have, and we want to make sure that we have our suction set to the order level that the provider has ordered. So we want to ensure that we have, first off, sufficient suction coming from our wall suction. And so on something like the atrium unit, we're going to actually have these orange bellows that pop out to let us know that we actually have enough suction in place. And they recommend at least negative 80 centimeters of water for the suction level coming from the wall unit. Obviously, the amount that's going to the patient is going to be determined by the drainage unit itself, but we want to make sure we have enough suction going to the drainage unit to achieve the appropriate amount of suction that's ordered. And then if our patient is actually off of suction and ordered to water seal, then we actually want to disconnect the tubing from the unit itself, and this will allow the free flowing of air out of the top of the drainage unit. In the cases of the atrium unit, when we have the patient to water seal, we're not going to see those orange bellows expanded because we don't have the suction in place. And then lastly, the last thing that we want to be assessing for is going to be the tubing itself. So it's really important that we're avoiding any kinks or any occlusions in the tubing, because this would essentially be the same thing as clamping the tubing, which could potentially be a problem for our patient. Another thing to be on the lookout for is to ensure that we don't actually have any dependent loops in the tubing. So this would be where the tubing comes down and then goes back up before coming into the drainage unit. Having these dependent loops will actually increase intrapleural pressure and prevent the lung expansion. We also want to be ensuring the integrity of all of our connections in our system. And so here we're going to be using tape to ensure that that connection is secure and won't come undone. And really the best way to do this is to do a spiraling connector of tape. And this way you can always rotate the tubing around and see every part of that connection, as opposed to if we just ran tape straight around the tube. That connection from the chest tube to the tubing is a spot that is high risk for clot development as well as entrapment of clots, so it's really important that we have a good visual of that location. Alright, so those were the main things that we want to be assessing for when it comes to our patient and their chest tube. There are a couple things I do want to hit on and cover with the remainder of this lesson that certainly are going to be important for you as well. The first of these is going to be sampling. This doesn't happen very often, but there's a couple different ways that we can actually get a sample of the drainage of our patient. The first is there's often going to be a sample collection port down at the bottom of the tubing where it connects to the drainage unit. And here this is usually like a lower lock connection for a syringe. So you just want to get the fluid down there towards the bottom, dependently collecting the fluid down there, and then hold the tubing just right so that fluid is hanging out near the bottom where that connection is, and then draw up our sample from there. Now, in a lot of these systems, we can also sample with a needle directly from the tubing itself. And so here we want to make sure and clean the site with alcohol, and then we want to use a 20 gauge or smaller needle, but we can just insert it directly into the tubing, make sure we have that dependent collection of fluid, draw out our sample, and then that tubing is actually going to be self-sealing, so we're not going to have to do anything after that. Now, the next thing I want to talk about is a really important thing for you to know, and that's going to be how to deal with a dislodged chest tube. So it's really important that if you have anybody that has a chest tube, there's certain things that we're going to want to make sure that we have at the bedside. So you always want to have petroleum gauze, 4x4 gauze, a transparent dressing, as well as a chest tube clamp available. And so the first thing that I want to talk about is actually going to be if we have a disconnection of the tubing to the chest tube itself. So if this happens in front of you, the very first thing you want to do is grab and cover the end of the tubing with your hand, and then if you can, get the clamp and clamp that chest tube. Again, it's going to be really important that at this point that whether we're covering it with our hand or we have it clamped, that time is going to be of the essence here. Now from there, we want to actually take the end of the chest tube and insert it into sterile water, and then unclamp that chest tube. Doing this is going to reestablish that water seal and will buy us a little bit more time to get a new drainage unit set up. From there, we want to prepare that new sterile drainage unit and then get that reattached to the chest tube. And then make sure that you let the provider know immediately, and here you're probably going to be expecting a chest x-ray to be done. Now, in a more severe case where the chest tube itself has been dislodged or completely pulled out of a patient, first off, immediately you want to cover the insertion site with your hand and then call for help. Now, if your patient is able to assist you, you want to have them cough and exhale as long as they possibly can. And this is going to keep air from re-entering that pleural space, but make sure that you're uncovering with your hand while they do this and then recover when they're taking a breath. From here, we need to prepare the sterile occlusive dressing. And so from here, we're going to take the petroleum gauze, we're going to open it up, put it underneath probably 3 or 4 pieces of the sterile gauze, lay that over the insertion site, and then from here we're going to take the transparent dressing, put that over the gauze, which has the Vaseline gauze underneath it, and we want to create a 3-border seal. So essentially all sides of it are sealed except for one side, here typically going to be the bottom. And so this is going to allow for the air to escape, but then keeping that seal, not allowing the air to come back into the chest. And then obviously let the provider know immediately after this has happened, because a tension pneumo is something that can potentially develop for this patient. And then here we're going to be expecting that chest x-ray to be done, as well as potentially reinserting a new chest tube for this patient. So I would have everything that you need in preparation for that to take place, potentially as quickly as possible. And then lastly, I did just want to cover a couple points of maintenance when it comes to the patient on the chest tube and the drainage unit. So the first is going to be if our drainage unit is actually full. And so when this happens, we're going to have to replace that drainage unit. Now, if you're using the atrium setup, which again is usually the most popular one that I've seen, here we're going to want to actually clamp the tubing with the big blue clamp that's on there. Once that's done, it may also be helpful to clamp the chest tube with a chest tube clamp just to ensure that we have a good clamp there. And then at the top of the accordion tubing, just coming off of the drainage unit, you can actually disconnect the accordion tubing from the standard tubing and then reconnect that to your new drainage unit. Make sure that when you do reconnect it that you feel and hear that click as the tubing is reconnected. Then from there, unclamp the tubing as well as the chest tube if you have that clamped as well. You also want to make sure and keep an eye on the level for your water seal. So you want to make sure that it's maintaining at the 0 level. There's going to be a line marked on there, and that's going to give us that 2 centimeters of water seal. Also make sure that we are avoiding those dependent loops in the tubing, so it's pretty easy for those to come up, especially with movement, so just always be keeping an eye on that and readjusting your tubing. And then there's always the debate about to milk or not to milk our chest tubes. And this is essentially when we are working to get the fluid. Typically, this is going to be with bloody sanguineous drainage, as well as any potential clots moving and continuing down the chest tube to our drainage unit. And so milking and stripping, especially when this is done aggressively, that this can actually lead to high negative pressure in that intrapleural space. So really the best practice is not to do this. Unfortunately though, I've seen this firsthand in a lot of different facilities. There's going to be particular providers who still want this to be done. So that said, if you are doing it, you really want to make sure that you're avoiding that aggressive, strong, repetitive stripping. When you do, make sure that you're clamping the chest tube tightly with your fingers closest to the patient and then carefully pull down to move the fluid and clots along the area that you're doing this. Sometimes taking something like a lotion can help to really create a good surface for a nice, slow, smooth stripping action. That said, the best practice is, like I said, to avoid the stripping and to do something like pinching. And so here you actually want to pinch around the chest tube, so pinch and release, and then kind of work your way down the chest tube. As you're doing this pinching and moving, you can turn and rotate the tubing along with doing these pinches, and this is really going to help to move the fluid and the clots along. And then finally, the last thing, kind of a pretty simple thing here, and this is going to be just making sure that that drainage unit stays upright. Oftentimes we'll have a stand, so you want to swing the legs out to keep a good stable base on it. Be cognizant of it in the room, be cognizant of the suction tubing. We don't want to be tripping over that or kicking the drainage unit and knocking it over. That said, if it does get knocked over, it's not necessarily the end of the world. Make sure you sit it up right away. And at this point, we want to be checking the integrity of the system. So make sure that you have enough water and at the appropriate level in your water seal. You also want to keep an eye on your drainage levels. Now, a lot of the units will actually allow you to tip the unit to the side. This is going to facilitate the drainage going back to the right into the appropriate chambers to fill up first that they're supposed to be filled in. And these systems will allow you to do that while still preserving the integrity of the water seal on the other side. So once you've done this, you've gotten the drainage collected appropriately where it should be, put it back flat like it's supposed to be, and then again, check that water seal level and make sure that's at the appropriate spot. And we do have hangers on there as well, so that may also be a secondary check to having the stand out as well as maybe having the hangers in place, as well as when you are transporting a patient that we want to use those hangers to ensure that the drainage unit stays upright. Alright, and that finishes this lesson talking about the basics of our chest tube and the system and our assessments that we want to do for our patients that have this. Covered a lot of good information in here. Hopefully you guys got some good nuggets of wisdom and knowledge from this lesson, and that you can take this information and apply it to your patients moving forward that have a chest tube. So I hope that you guys found this information useful. If you did, please leave me a like on the video down below. It really helps YouTube know to show this video to other people out there, as well as leave me a comment down below. I love reading the comments that you guys leave, and I try to respond to as many people as I can. Make sure you subscribe to this channel if you haven't already, and a special shout out to the awesome YouTube and Patreon members out there. The support that you're willing to show me and this channel is truly appreciated, so thank you guys so very much. If you'd be interested in showing additional support for this channel, you can find links to both the YouTube and Patreon membership down below. Head on over there and check out some of the perks that you guys get for doing just that, as well as check out some of the links to other nursing gear, as well as some awesome t-shirt designs I have down there as well. Make sure you guys stay tuned for the next lesson that I release. Otherwise, in the meantime, here's a couple awesome lessons I'm going to link to right here. As always, thank you guys so much for watching. Have a great day.